Welcome to the American Academy of Child and Adolescent Psychiatry's forums on how collaborative care enhances your practice and increases child mental health access. This is the introduction to the Collaborative Care Virtual Forum. My name is Abigail Schlesinger. I'm the Clinical Chief of Child and Adolescent Psychiatry and Integrated Care at UPMC Western Psychiatric Hospital and Children's Hospital of Pittsburgh. I'm also an Associate Professor of Psychiatry and Pediatrics at the University of Pittsburgh School of Medicine. I'm delighted to be here today to give you an introduction to both our virtual forum and the experiences that are to come available for child and adolescent psychiatrists that are members of ACAP. Today is the introduction to our virtual series that will include 6 sessions that can be accessed at your leisure. The name of the series is How Collaborative Care Enhances Your Practice and Increases Child Mental Health Access. As you can see, there will be 6 lectures that will be presented asynchronously. You can access them when you want to, but they are meant to give you anyone interested in doing collaborative or integrated care the basics, as well as some advanced concepts that they can ponder as they think about being in this fabulous field. Today, for the first virtual session, we're going to focus on the basic terminology, as well as whet your appetite with brief videos from myself and 5 other child and adolescent psychiatrists to do integrated care, where we are going to tell you why we love integrated care, to make you all think about how you could possibly do it as well. The overall 6-session series has these 4 learning objectives. I'm not going to read them to you, but it's important to note that we focused on several models of care that we think are pertinent for child and adolescent psychiatrists to know, that we want you to think about how implementing these models can transform your care. We also understand that sustainable funding is vital, so we've included a session on that. And we also want you to think about how doing collaborative and integrated care can help you be a leader, and also how you can advocate for efforts in this direction. Next, you're going to hear from my friend and colleague, Dr. Emily Harris.
Hi, I'm Emily Harris, and I'm a triple board graduate, and I practice both general pediatrics and child psychiatry as an outpatient, and I absolutely love the collaborative care model. It makes a lot of sense, and it helps support pediatricians, especially in primary care, as well as subspecialties, to learn to recognize and feel comfortable identifying and managing early childhood mental illness as it's starting. So it's a great model to help support pediatricians, because primary care, they don't get a lot of training on how to identify or manage mental health issues, and they need our help. So it's a great model to kind of build a foundation and then offer support and specialty advice about how to implement the algorithms that are out there, and also to make great connections with fantastic clinicians who are doing so much work, and they need our help. And it's a nice way to kind of get kids care and access to these algorithms of care that we know work. And in primary care, they see the kids at this unique opportunity before a disorder can develop or is developing. And I feel like there are gaps that we can fill in this collaborative care model. So I really love it. And I've made some excellent connections over the years, and I can't foresee doing anything else that uses both the pediatrics and the psychiatry in such a great way. So I love it.
Before we get started with the basic information that we're going to provide today, I'd like to thank the committee that helped work on this series. These psychiatrists have all been involved in collaborative care from private practice to academic centers, and are at different stages in their career. We've been working on this for over a year and are all very dedicated to the idea of improving the ability of our child and adolescent psychiatrists throughout America and the world of providing more care along with their pediatric colleagues. These 6 sessions as I talked about earlier, are going to be released simultaneously in January 2025. The mission of this collaborative is that we want to help child and adolescent psychiatrists understand and expand their potential roles providing collaborative care in the pediatric medical home. As I said, in January 2025, the 6 sessions will be released simultaneously and will be available for free for anyone who's a child and adolescent psychiatrist and a member of ACAP. Later in 2025, we will have 3 live opportunities to interact with CAPs providing collaborative or integrated care. And they will be scheduled, and there'll be chances to answer questions and learn more things about collaborative and integrated care. We expect to have ongoing opportunities after that to build this cadre of psychiatrists that are able to provide services in pediatric primary care. I bet you can't wait to hear from our next integrated care psychiatrist, another friend and colleague, Mark Borer.
This is Mark Borer, and I'm a child and adolescent psychiatrist, and I'd like to tell you why I love collaborative care. My child psychiatry training was in a multidisciplinary program in Charleston, West Virginia, where we learned from and respected each of our collaborative partners. Delaware, where I live now and practice, is a small state without its own child psychiatry training program. We have a shrinking number of child psychiatrists, so waiting lists are long. We have a great need to increase access to psychiatry services, both direct care and through consultation with clinicians or collaboration with them. And these are kids that I may or may not get to see in person. I run a small private practice and have contracted many years with various community agencies, and State of Delaware is a component of practice, allowing me to work with a wide range of youth and families. I really love collaborative care and providing care through 2 evidence-based programs in youth. We have a Child Psychiatry Access Program, DCPAP, here in Delaware, and a Pediatric Collaborative Care Model, or CoCM, because I can now offer help to a wide variety of youth through collaboration with their primary care teams in conjunction with other mental health and school programs in the community. So I get the best, my own private patients, my contracts with schools and community agencies, and now my primary care work through CPAP and CoCM. I meet more needs for more kids and families while having good relationships with partners outside my own office. Not only has collaborative care helped increase access to care, but primary care physicians report feeling supported and enjoy the consultation, which may also help them feel less isolated and have less burnout in working with youth with psychiatric and behavioral health issues. In mentoring trainees from medical students through child psychiatry fellows, as well as early career psychiatrists at our annual meeting, I found wide interest in their learning and pursuing collaborative models as a component of their own practices, adding variety and intrigue to child psychiatry ventures. Small practices and large programs alike are implementing collaborative care. CPAP programs are supported by HRSA grants as they develop the consortia of payers, insurers, and states to support sustainability. Collaborative care model in pediatrics is currently sustainable by collaborative care code submitted by the primary care practice on behalf of the delivery team, which includes an hourly rate for the child psychiatrist. Our family medicine residents are as excited as our pediatric colleagues and residents. In summary, collaborative care, it's possible for you to do, it's needed, it is sustainable, and it's fun. Please participate in our upcoming interactive virtual series on collaborative care for a better picture of implementing each model, which will include later scheduling of a question and answer period to help each of you to be inspired. Transforming or enhancing some portion of our daily clinical practice through collaborative care is the way we must go to keep our field viable and available to all those in need. Thank you very much.
So once again, these are the 6 asynchronous, you can tell I have trouble with that word, and I'm probably going to have trouble with it when I say it again, but essentially these are the sessions that are being taped that you will be able to watch at your leisure. Each of them are no longer than 45 minutes to an hour and really designed to whet your appetite and educate you about the basics of collaborative and integrated care. You'll notice that I use the term both collaborative and integrated. We will talk more about that in the future in the next couple slides. But today, that we are working on collaborative care, what it is, and why we love it. So the learning objectives for this session are that we really want you to understand some of the basic models of collaborative care. The Child Psychiatry Access Programs, or CPAPs, the collaborative care model, often called CoCM or CoCM, and the primary care behavioral health model, or PCBH. Although there are many methods to provide mental health in primary care, we feel that these are three models that you must be aware of in order to start a program or grow a program in the United States. We also want you to understand the role of a CAP, or child and adolescent psychiatrist, in each of these models. Begin to understand the advantages and challenges of collaborative care as a component of practice, and be motivated to pursue collaborative care. Hopefully the videos that you're seeing in between my slides will motivate you, if nothing else. Next, you're going to hear from another one of my friends and colleagues, Dr. Ning Zhou.
Hello, my name is Ning Zhou. I use he, him pronouns, and I'm an early career child, adolescent, and adult psychiatrist. And I work at the San Francisco Department of Public Health in San Francisco, California. I work in two different integrated collaborative care settings. So one is a larger primary care clinic where I consult to a team of primary care providers as well as behavioral health clinicians. And then the other clinic is a more specialized clinic that focuses on working with queer and trans youth. So I enjoy working in both of these different settings, and the way I work is a little bit different based on the size of the clinic. And in the clinic for queer and trans youth, I do directly see some patients and have a small panel. And then at the larger primary care clinic, I mostly don't directly see patients myself, but I'm a consultant to the primary care providers as well as the behavioral health clinicians. What I like most about collaborative care and integrated care is the teamwork aspect. I really enjoy collaborating, connecting, and coordinating care with people from different disciplines, including the primary care providers, the behavioral health clinicians, the medical assistants, the nurses sometimes as well. Something that I also really enjoy is the breadth of the types of questions that come up, and I feel like it really challenges me intellectually. Sometimes I'm looking up things to find what does the latest evidence show, what are current best practices, so that I can be providing evidence-informed recommendations. And then I also appreciate being part of a community of other consulting psychiatrists, so that if there's questions that I don't know, there are other people that I can consult with and receive their kind of guidance as well. Some of the other things I really enjoy are teaching and providing trainings to the primary care providers and the behavioral health clinicians, and really increasing their skill level in diagnosing, treating various mental health conditions. I also really enjoy the aspect of like reduced documentation burden. So when I'm working as a consulting psychiatrist, I do document, but usually my notes are more brief and different from when I'm the main provider for a patient, and which is much more thorough and extensive. So those are some of the things that I really enjoy about integrated and collaborative care. I find it to be really rewarding. I really enjoy working in multiple settings, and I think it's a different way of using our skill set where we are, in many cases, not directly evaluating patients ourselves, but relying on the report and the mental status exam of our colleagues and other, behavioral health clinicians or the primary care providers. So yeah, in summary, I really enjoy collaborative care and integrated care, and really find it to be rewarding work, and also intellectually stimulating work. And the relational side is also very fulfilling. And I've found that investing in those relationships with my other team members has been really, really helpful. One, in feeling a sense of cohesion with the team, and also feeling that we're all working kind of at the top of our capacities and licensure. So thank you very much.
So let's get on to the content. Today, before you dive into the rest of the 5 videos that are created, we really felt that it was important that we talked about definitions and models. For some of you, this may be the first time you're hearing some of these terms. For others, you may have heard some of these terms, but be unable to differentiate them. So we're really going to do a 10,000-foot view today to help you understand these 5 basic concepts in collaborative care. And as you'll note, I'm going to often use collaborative and integrated care interchangeably, except for certain things, which we'll talk about in the slides to come. Again, many of these concepts will come up again and again in these next 5 hours that are provided to you, but we wanted to get everyone a baseline so that we're using the same terms. So since we are talking about working with pediatricians and primary care providers, I'm actually going to start in describing the models in a slide that was actually designed by one of our pediatric primary care colleagues. I'd like to thank Marian Earls, who will be presenting in the next lecture, for allowing me to use this slide. And she's talking about ways in which you can collaborate or co-manage with pediatricians. This slide was actually presented to pediatricians in the American Academy of Pediatrics in 2024, and will probably be presented again. And some of these things probably already sound quite familiar to you if you look on the left side of this slide. So if you look down on collaborative and integrated care as if it was an egg, the yolk is that light blue, and that's referral and feedback. So for many pediatricians in the United States, they don't have access to complicated or sort of unique systems of care. They are in rural areas. They may have access to a psychiatrist that they can send patients to. And those psychiatrists also may be in private practice or in mental health centers. And for many psychiatrists and pediatricians in the United States, referral and feedback is the primary way in which they interact. And my pediatric colleague, Marian Earls, really wanted to make sure that all psychiatrists that see children and youth recognize that referral and feedback relationship is vital. And it may be the only way that pediatricians have access to psychiatrists. When we in our committee have talked about getting people involved in collaborative and integrated care, we've also talked about how developing a relationship with your local pediatrician or primary care doctor and developing a consistent referral and feedback mechanism can be the beginning of thinking about unique and novel ways to interact. But regardless, having a consistent way that you communicate between psychiatry and primary care definitely improves the quality of care, as well as the quality, I think, of not just relationships, but of careers for psychiatrists and pediatricians and primary care doctors. From referral and feedback, we moved to consultation, which many people are aware of from doing consultation on the inpatient world when they were trainees. There are also many mechanisms of consultation in outpatient, one of which we'll be talking about soon. And then the outer part of this egg is co-location and integration. And we'll be talking more about those different models of co-location and integration throughout this series. So the first definition, collaborative care. Collaborative care in the current rubric simply means any physical health, mental health collaboration that fits within the six levels of the collaboration continuum. So there's a couple things I said here in this picture that may confuse people, but I put this here purposely to make a point. First of all, collaborative care is a general term that's used to describe the entire continuum from minimally collaborative to very closely collaborative or integrated. Notice on that screen it says collaboration continuum. This is from 2010. Also notice that there's only 5 levels there, not 6. And the important point I want to make here is, one, I think that this was out in 2010 in the Miliband report, led people to believe that for some reason we should be moving along the continuum all the way to the right side. And if you're not to the right side, you haven't gotten all the way. Really, collaboration is local, and collaboration can vary greatly depending on what is needed in the local environment. So first of all, this is wrong because there's more than 5 levels that we've determined. And also, it is not the goal of everyone to move to the top level. The goal is to do what's right for the environment, for the physicians, for the patients which we serve. So in this slide, also making a point that collaborative care alone just means any collaboration between physical health and mental health. So I know this is a busy slide, but it's an important slide, an important thing that everyone that's interested in behavioral health should be exposed to. Released in 2013, it was really one of the first mechanisms, first attempts to truly draw out what the different levels of collaborative care are. And if you focus on the top in that sort of dark red area, there's coordinated care. That's level 1 and level 2. The basic and key element, as they say here in coordinated care, is communication, meaning communication between the primary care doctor and the specialist, which in our case is a child and adolescent psychiatrist. Remember that egg we talked about? That's really the yolk, right? Level 1, although it says minimal collaboration, that's the yolk of services for most people, is the communication between a child and adolescent psychiatrist and the primary care doctor. And then as we move to the blue on the top, there's co-located services, where the key element in co-located services is physical proximity of the primary care physician or providers and the child and adolescent psychiatrist or the mental health providers. Finally, as we get to integrated, and many times people will use the term integrated to suggest that we have moved further along the continuum and we really move towards practice change. So as you notice in my video, when I say what I love about collaborative care, I'll go back and forth between saying collaborative and integrated care because I really believe that I work in some settings that have truly had practice change. But it's not wrong to also say collaborative care because the entire spectrum is collaborative care. And again, integrated means that you've not just gotten close to each other, communicated more, but there's been true practice change. I recognize that the pieces on the bottom are a little smaller and a little harder to read. So I have another slide so that we can talk a little bit more about coordinated, co-located, and integrated. Remembering again that coordinated, the key element is communication. Co-located, the key element is physical proximity. And integrated, the key element is practice change. And it moves from level 1 all the way to level 6, where full collaboration is really a transformed practice. And when you think about these three sort of buckets of collaborative and integrated care along the spectrum, you can think about how things are coordinated, co-located, or integrated in terms of location, communication, or systems. So we talked about location already, right? Co-located, the key element is physical proximity. For communication, as you work along the spectrum, you're working towards discussion of factors that impact behavioral health for all patients. So something that was fully integrated or level 6 in terms of communication, every patient would have a discussion of behavioral health concerns, preferably with a therapist or a psychiatrist. When you look at systems that are fully integrated at level 6, we're working towards systems that truly support team-based care for all patients. So shared charting, shared care strategies, and these shared care strategies support not just treatment, but prevention. And as you approach a fully integrated system, you'll start to see blended cultures and roles for all the members of the team. This can be a little confusing, and I don't expect everyone to entirely be able to come out of this an expert. But when you start collaborative or integrated care, you need to define roles so everyone knows what they're doing. And we'll talk more about roles and how to understand what pediatricians can and can't do in the next hour. But today I want you to know that even though you clearly need to define cultures and clearly need to define the roles as you're building a program, and understand that the cultures are different between behavioral health and physical health, that as you get more integrated, both the cultures and the roles will blend. And that's the reality of becoming a fully integrated system. You may also have noticed now that you could be integrated in some ways, but not others. So it's often not so simple as saying, hey, I'm a level 5 or a level 6. You could be a level 6 in some ways, and maybe even a level 4 in others. So there are many ways that you can integrate. Next, you're going to hear from yet another friend and colleague in the integrated care world, Dr. Barry Sarvet.
I am really pleased to share with everybody, what it means to me to be doing, this kind of work and why we think it's so important. I started to get involved in working collaboratively with primary care providers, particularly pediatric primary care providers, as a child psychiatrist. When I first came to a setting to lead the child psychiatry services in a health system, and we had a really dire shortage of child psychiatrists at the time. That we've really built a really nice team in the meantime, but it really was pretty grim. It was very stark, and in order for me personally to survive, I actually found myself, needing to design different ways to improve access to care, and to really be able to help, the pediatricians who were doing, a lot of the child psychiatry work that that I was trained should be done by child psychiatrists. And so I actually started looking at some of the practice of the pediatricians and realized that they actually were doing, in a lot of ways, a very nice job, but they just needed help. And I also, another reason why I got interested in this is because actually I mentioned in my presentation that I, have been a member of ACAP for sort of about 30 years, I think more than 30 years. And at the beginning, I sort of noticed that child psychiatrists, were kind of marginalized and were marginal in a lot of ways in the mental health system, just because there weren't enough of us actually engaged in providing care to, some of the more, the most complicated patients in our community. And we were really leaving it, to others to worry about that. I think a lot of people, not everyone has to do everything in their profession, but as a profession as a whole, the profession needs to be concerned, and I've always felt this way, with the patients who need help and aren't able to get into our door, able to see us. And so I came to the realization pretty early on in my career that the only way forward to really have more of a public health orientation in child psychiatry is to find partners. And I actually discovered that some of the most potent partnerships for helping kids would be with pediatricians, because I felt like we have so much in common, child psychiatrists and pediatricians. The state of our relationship between the two specialties was very troubled at the time, but there's so much potential, because we had shared values and shared interests, and somehow we went astray in our relationship with pediatricians because of the enormity of the need and people kind of wanting to kind of protect themselves from being overwhelmed, with the needs, in the community, and controlling their practice, which is, I think, something that people, who go into private practice really focus on, the care of the patients that they're actually seeing in their office, and it's harder for them to look, at the whole population. And so that's really the reason, and I've enjoyed it so much. It's the opportunity for child psychiatrists to get involved in prevention, and really trying to address issues of well-being and really strength-based, kind of work, because the primary care setting is really all about that. And specialty care, I think, is focused more on sickness and not as much on wellness. And so this is an opportunity for us to get involved in wellness. In addition, it gives us a chance to get involved in trying to improve standards of practice for sort of the majority of patients in the community with mild to moderate kind of severity of illness. It also is a wonderful way to have variety in your practice that I've always recommended to early career psychiatrists, that they consider incorporating collaborative care into their practices. But I actually think that most of us really need to do a variety of things, and including taking care of the sickest, kids, the kids who have the most severe needs, because that's where our specialty really, comes in handy, for the direct care. So it's really just part of a portfolio of different activities, and it makes your career, it's made my career extremely gratifying. And then lastly, the relationships that I have been able to enjoy in my career with pediatric primary care providers and pediatricians and family medicine providers have been just so satisfying and delightful, again, because of those shared values and joint advocacy that we've done together. And it's just so nice to be able to connect, with people who have different perspectives, than ourselves. So that's why I advocate for collaborative care. That's why I recommend that everybody consider, finding ways of getting involved. And we're here to help, at ACAP as well.
So we talked earlier about coordinated care. Remember, that was on the left side of the spectrum. Coordinated care, again, is when behavioral health and physical health are in different locations, but there are systems in place to support collaboration. There are many ways in which you can do coordinated care, but a very important one that child psychiatrists know about exists in child psychiatry access programs, or CPAPs, as we call them. And you will hear me call it CPAP. Important to recognize that in this situation, a CPAP has nothing to do with breathing, but is a child psychiatry access program. And these programs were designed to support pediatric primary care providers so they can provide high quality psychopharmacology management. I'll talk a little bit more in the next slide about what they exactly are, but they are essentially a coordinated care service where the psychiatrists are not part of the primary care offices, but are available to provide consultation. The role of the psychiatrists in these coordinated care programs, in these CPAPs, is to lead the programs, provide the phone consultations to pediatric primary care physicians, to lead and provide education about common behavioral health conditions, and to complete the patient consultative evaluations. This is the least of the roles that psychiatrists can play in these programs. So what is a CPAP, or a child psychiatry access program? So at its very basis, child psychiatry access programs, which by the way are in most states now and growing, is that there's a psychiatrist available to answer the phone, often same day, if not within a half hour, to provide curbside consultation to a pediatrician or primary care doctor who's serving a kid. These have also been extended into perinatal programs, so women that are in the perinatal period as well as adults. But let's focus on child for now. So if a pediatrician or primary care doctor has a child in their office, say they have ADHD and they're not doing well with their medicine, they can call and get a child psychiatrist on the phone to help them talk through what the needs of the child are. The goal of the phone consultation is to help that child get the maximal treatment in primary care, but if it seems like specialty care is needed, to help move the child to the appropriate level of care. Many programs also offer evaluations. So for example, our CPAP, we say if on the phone we can't figure out what exactly the needs are, or say that there's issues around diagnostic clarity. Those are two big reasons why we will do evaluations with a therapist and a psychiatrist. Oftentimes it's within a brief period of time, so we are actually mandated to see the patients within 2 weeks and provide that information back to the primary care doctor so they can help with management of whatever the needs of the youth that we're seeing. And then many programs also provide care coordination. So once the psychiatrist and sometimes the therapist sees a patient, makes the recommendation back to the pediatrician, there are care coordinators associated with the programs that can help the child and family get their needs met. Sometimes the care coordinators can also train the primary care practice to provide some care coordination on their own as well. The other important things of these, other important roles of these CPAPs is providing education. So all of the CPAPs that I know of go out, they educate pediatricians, they do a wide variety of mechanisms to help pediatricians get additional training about not just psychopharm, but therapy, trauma, and other things. that's formal education. Also in these phone consultations, even though they are brief, there are opportunities for education there as well. And NNCPAP is the National Network of Child and Adolescent Psychiatry Programs, where all of the states and different programs that are provided throughout the nation meet to develop the program. Next, you're going to hear from my friend and colleague, Aleiya Butler Wright.
My name is Aleiya Wright, and I am a child and adolescent psychiatrist. I love collaborative care because of teamwork. On our team includes myself, the care coordinator, and the primary care providers who are on the ground seeing the patient. Together, we bring energy and vitality to do the work of delivering quality mental health care to those in need.
The next definition that is really important for everyone to know about, in fact, we'll be expanding quite a bit about this in the upcoming hours, is the collaborative care model. So this is often called CoCM, CoCM, or CoCM. This can be a little bit confusing because remember how I said collaborative care means everything, just like psychotherapy can mean lots of different psychotherapies. Collaborative care model, or CoCM, as I'll call it, is actually an evidence-based way to provide collaborative care. So a little bit confusing. I'm going to say it again. So when I talk about the collaborative care model, or CoCM, that's actually an evidence-based model that's been proven to be effective for providing behavioral health care and primary care. People often misuse this term and talk about collaborative care and CoCM interchangeably. If you're talking to someone who's talking about collaborative care, it's often important to clarify, are you talking about collaboration in primary care, general collaborative care, or are you talking about the collaborative care model, or CoCM? Sometimes people say collaborative care with a big C or the with a big T. There's lots of ways people may shortcut it, but you need to know, are they talking about the evidence-based model or the many different ways to collaborate, all of which improve care but have less data than the CoCM model does. And in the CoCM model, there's a behavioral health care manager who manages a population of patients with a registry using measurements so the pediatrician can then prescribe medicine. So the behavioral health care manager meets weekly with a psychiatrist who makes recommendations back to the pediatrician about different options for the child. That could be about stimulants or medicine, or maybe we need to consider a higher level of care. It's often called a triadic model because we have a care manager, the patient, the medical provider, and the psychiatrist. The psychiatrist in the situation doesn't usually see patients. They meet with the behavioral health care manager once a week, review the registry of all the patients that they've worked with. The care managers also have an interesting role, although they provide basic psychotherapeutic interventions. They don't generally bill what's classically considered psychotherapy billing, and are able to have more flexibility in doing phone calls, brief interventions, and despite that, not doing classic psychotherapy, they've been shown to have a lot of effect in helping youth with depression, anxiety, ADHD, and lots of data in the adult world. I don't expect you to be an expert in collaborative care from this brief introduction. There will be a lot more about collaborative care in many more of the videos if you choose to watch them. So, but I do want to talk a little bit about the evidence for the different integrated care models. So there is a weak but significant effect for all of the different models that I've talked about. Generally, mental health treatments have better data than substance use treatments. And this information I'm giving you is predominantly from the Asarno review of, but it's also from a CoCo article as well as one by Wright. Treatment models show more effect than prevention. So full-blown collaborative care models, remember that CoCM, CoCM that I'm talking about, they have moderate to large effect sizes. And other models in this review of Arsana, they were called integrated care models, but any model that put people into the practice and had coordinated care had small to moderate effect sizes. So And then CoCM models have been shown to be a cost-effective method of treating externalizing disorders in youth and adolescent depression. So there's clear evidence in adults and lots of evidence in adults, but also this bit of data in the child and adolescent world showing that full-blown CoCM models, remember that's that triadic model with the care manager, have been shown to be cost-effective and a way to provide treatment for externalizing disorders and for adolescent depression. So deep breath, the next thing we're going to talk about is the primary care behavioral health model, or PCBH. So PCBH is different from what we've described so far. It's different than CoCM in that there is a therapist in the office and not necessarily a psychiatrist present. So PCBH does not require a psychiatrist to participate. And really, there can be any variety of relationships with the therapist and the primary care physician when you have a therapist that is integrated in the office. But our pediatric colleagues are learning these days that there's something called a fully integrated PCBH. So this is one that's all the way as integrated as they possibly could be. Oftentimes, this is like the other thing that they've been calling this is sort of fully adherent to PCBH. So primary care behavioral health model that is fully adherent to the primary care behavioral health model, or PCBH, has a therapist available real time for every patient and caregiver. Because they're available real time, the pediatrician or primary care doctor can do warm handoffs to them. They may also do huddles daily, weekly, or monthly to review the patients that are being seen. Notice this is much different than CoCM, where there's not generally a warm handoff component, and there's a psychiatrist inherently involved. Here, there is a therapist, and the way that our primary care colleagues have been learning about this in pediatrician is that this person is there to do warm handoffs, to do a lot of prevention, to potentially even intervene with the adult if need be, and that they're doing sort of population health-based management for every person that enters. Again, there's lots of therapists integrated in practices that aren't necessarily fully integrated. So another thing that if you get involved with a program like this, it's important to know what exactly are the therapists doing in that office. So again, a CAP can definitely be involved in this and can potentially have many roles, which means if you're asked to join a primary care behavioral health model or a model that has a therapist integrated in the office, you need to ask a lot of questions about what they want you to do, what you think you can do, what you need to bill for. Oftentimes, these therapists in the office are billing on the medical side, meaning they're not billing behavioral health insurance, they're billing the medical insurance, or they're billing collaborative care codes. If they're going to use you to bill psychiatric codes, that is going to require more work on the practices part. And we're going to have a lot more talk about the things you need to ask if you're going to be joining a practice, but just something to know that if you're joining a practice that already has therapists, and certainly if they have a fully integrated PCBH, you need to ask a lot of questions and think about what your role should be before you jump in head first. And again, this CAP, you could have a role as a child and adult psychiatrist to just work with the PCPs, to just supervise or provide interventions with the therapist, or both. There's even been some suggestions of using PCBH and CoCM together, where some of the therapists do CoCM and work with the psychiatrist as well. You can do education, consultation, you can design care strategies for the team, and you could also provide direct care. Some people that I work with once called this co-location with benefits. I think the benefits are predominantly for the primary care team, but it's also, having worked in a co-location model at one point, it's also a great way to see what really happens in pediatrics. Finally, this is why I love integrated care. Hi, my name's Abby Schlesinger, and I'm an integrated care child and adolescent psychiatrist who's been working with primary care practices for over 20 years. I love integrated care work because of its effect on me, my pediatric partners, and my community. When I talk about me first because I've gotten so much out of doing integrated care. I learn something new every day, and my pediatric partners really teach me to think differently about how to serve youth and families. The impact of integrated care on my pediatric partners has also been amazing, as I've watched so many pediatricians and primary care doctors develop new skills and help children and their families in new and exciting ways. Finally, integrated care has a huge impact on the community, as I've seen so many more children and families get help earlier, faster, and in more effective ways. Really, integrated care has changed the nature of how I do my job and has improved my community. And I wouldn't have my career any way different. So we've made it through our basic definitions. If you remember before, I had a slide that just had these words down, but not the definitions after them. This is actually the collaborative care, which again means the entire continuum. Coordinated care, which is defined by, although not being physically in the same location, having strategies and ways to communicate. Child psychiatry access programs, which are an example of coordinated care. PCBH, which is one model where you incorporate a therapist into a patient-centered medical home. And collaborative care model, which is the evidence-based model that you're going to learn a lot more about in the next sessions. So we've made it through the basic definitions and collaborative care, what it is and why we love it. I hope you join us for the next sessions, as well as for the synchronous opportunities that we're going to have in the spring. We're really excited about these and excited to bring more people into the fold of people that see how great it is to do collaborative care, even if you only do it for a part of your career. Once again, the Collaborative Care Forum includes not just these 6 sessions that are released all at once, but the 3 live opportunities that are going to happen in the spring of 2025. Stay alert for that. These are references. I strongly recommend that if you're interested in collaborative care, that you take a look at our clinical update on collaborative mental health care for children, adolescents, and pediatric primary care. It's a great overview of some of the things we talked today, as well as ideas about how to do education, consultation, and collaboration. And the AIMS Center is definitely worth looking at if you're interested in collaborative care. This implementation guide is a nice overview and some nitty-gritties about how to do collaborative care. Finally, thank you to our people that agreed to do video clips on why I love integrated care. As you'll see, we have members of academic health systems, people from across the US, as well as private practice. Once again, thanks everyone for listening, and I want to thank our collaborative care psychiatrists for sharing why they love collaborative care.